Welcome to the second episode of What I'm Dying to Know, which is a podcast brought to you by Bethesda Healthcare Palliative Care Team. We're filming here today at Scotch College with a huge thank you to them, Sam and Will and the whole school. It's a real community initiative to allow us to have some open, honest conversations about palliative care. What is it and who's it for? Why does it actually matter? We know palliative care can be a confronting topic, and we know for a lot of people it can seem quite scary. But it's not all about death, and I think it's also about living well and focusing on things like quality of life, often for years. But we still see people at the end of life. We're about supporting patients and their families with comfort, dignity, and choice. In this series, we'll be speaking with the people who deliver this care every single day and sharing some stories, some insights, and hopefully a bit of practical advice. We also are going to be hearing from our Facebook community with some big questions to answer. So I'm Sarah Day. I'm the staff development nurse at the Palliative Care Unit at Bethesda Healthcare in Perth, and it's where I get to do my dream job every single day, which is chatting on about palliative care to anybody that sits still long enough to listen to me. I'm joined here today with Alison Bennett, one of our super experienced registered nurses on the ward, and she plays a huge important role not only in our team but also to our new nurses and has mentored many over the years. We're also here with Dr Adele Clair, who's one of our rockstar palliative care consultants, who's spent many years working in our team and out in the community doing fabulous work with her beautiful manner. So together we have several decades of experience, and hopefully we can share with you today some stories about what it is that we actually do in palliative care every day. Welcome, Adele. Welcome, Ali. Thank you for coming.
Thank you, Sarah. Thank you for that very kind and generous introduction.
You're welcome. It's absolutely true. Thank you both for being here. This is really exciting. So for our second episode today, we're discussing the role of carers, family and loved ones who come into palliative care with our patients. So often I feel that people really struggle to understand in the community, but also in healthcare, that anybody with a disease that we can't cure can come and see us from a palliative care point of view. And so we can be seeing people for years, which we explored in our last week's episode, what actually is palliative care. And this means that if the person doesn't understand this and if the families don't understand this, that they may miss out on vital support. So today we want to try and explain how we can support people's loved ones as well as them and make sure that they get the best out of the journey and living with a palliative diagnosis. I remember a young lady who was only in her 20s, and she actually came into the unit many years ago, mostly because her father kept sneaking cannabis into her sandwich, into her porridge in the morning, and she said, he needs some help just as much as I do. And it was amazing that she recognised this. So she checked herself into the palliative care unit, and we got to spend several months with her where we picked out her wedding dress and we got them married. And we were able to really go on that journey with her and support her dad and her loved ones to understand. And when she started to deteriorate, we could have those honest conversations and support everybody. So out on our Facebook page, we asked if anybody had any big questions. Karen Lockyer asked us, how are families supported in palliative care and how are they a part of the care plan? Adele, can you maybe explain a bit about why early support from us can help families as well as our patients?
Absolutely. And thanks, Sarah. And thank you, Karen, for an excellent question. So what we know is it's not one size that fits all, and there can be wide diversity in family structures, in caregivers, and important relationships, and also wide diversity in supports available. When we first meet the people who are looking after, it's a crucial part of that process to learn who these important people are and the role they play in our patients' lives. Living with a palliative diagnosis can affect relationships. Sometimes it can make relationships stronger. However, we do see a lot of the time very significant strain and stress as life changes and disease progresses. So not only is there stress with physical care needs, There can be financial, accommodation, decision-making burden, psychological and emotional strains, and usually fatigue is associated with each of these problems and each of these stresses. Palliative care offers support across all of these areas with what we call a multidisciplinary team. And a palliative care team typically will include nurses and patient care assistants, like doctors, not only palliative care specialists, but oncology specialists, include general practitioners and sometimes mental health practitioners. Allied health are very important in the process and in the care that we provide. We have specialised pharmacists, we have occupational therapists, we have physiotherapists, we have dietitians, we have psychologists who also are clinical psychologists who are a very integral part of the care. We have cultural supports in Aboriginal health workers, we also interpreters, and we also have volunteers or very special people to giving up their time at risk in the palliative care setting. Communication is something that plays a part in the care plan, and it's a space, we provide a space for challenging questions and conversations, to answer questions, to clarify and provide explanation or education, which can help with planning and preparation, recognising deterioration, and being aware of options available and treatments available. We also provide care in the final days of life and really have at it and include these important people at end life.
Absolutely, Adele. Thank you. That was a fabulous answer. I think what you're really describing is not only for the person, but for the families, that we have this holistic approach and that we're going to support you on all levels. So we support people with the physical symptoms, but we support people with all the things that help with conversations, difficult conversations with the family. We might support with cultural care and spiritual care. We see the person as a whole. And I think it's really good to mention that all families are different. So we see all different types of families come in. So a family member might just be your dog. And so we've absolutely facilitated where dogs come in and spend the last days or last hours with somebody. We might see huge families. So especially with our Aboriginal families, Aboriginal community, it's really important that we've got a good understanding about kinship and that will look very different. And often multiple people will be very important. And we facilitate that as best as we can, I hope. So, Ali, can you think of a person who we may have cared for recently where the family members played a really significant role in that?
Yeah, thanks, Sarah. I think it's often the case that the family is so intrinsically linked to the care that we are able to provide to the patient. One person comes to mind recently. Not recently. One person comes to mind, and that family were able to really utilise our wonderful cuddle bed, and she was able to spend her final days in very close proximity, cuddling her kids and her husband and even her siblings and her mum, and it was just a really special time that they were able to remain really close to her and really supportive. And then also they were able to then reach out to us when they observed changes in her or they had questions about her condition or her care. So it was really a beautiful sort of collective, collaborative approach that we had in supporting her in her final days with her family.
Thank you, Ali. It is, I think that cuddle bed, like you mentioned, allows all of our family members, whatever that looks like, to just be right there. And actually, sometimes they can be our call bell, which we talked about. Adele said that the other day. And I think that's a really good way to say it, is that they know the person much better than anybody else. Thank you, Ali. So, Ali, what do you think some of the signs may be if we have family listening today or people that have a palliative diagnosis? What do you think some of the signs may be that might indicate that their loved one may need to come and sit in a palliative care team?
Yeah, okay. So I feel like we see, as Adele said, a real diversity in people's family makeup. And in that diversity, we see that people have very different capacities. So some families are really able to provide a lot of care. There might be one particular caregiver that's able to be one-on-one and they're really willing to take that on. Some people might have a big family and so they share the care for a long period of time at home. But often it can get to a point, even if perhaps the patient's wish is to continue care at home, where the carers are unable to provide what's needed. Whether that's an exacerbation of a particular symptom that needs to come in and, then our wonderful team, our doctors will provide the medical care and insight to manage that symptom, and then the patient can be discharged home again. Or it might just be that there's carer fatigue, for the symptoms just become simply too complex to manage at home. And that's a great time then to come in and seek the support of our palliative care unit, and all that the team has to offer. And that can really provide a lot of relief for the families, to be able to step back a little bit.
Thank you, Ellie. I think that's really important that, yes, it might be physical need, but it might be the need of the family. And sometimes when we're doing that carer's role 24/7, they don't get breaks like we do. They don't get to go home. It's constant. And so that's really important to recognise when that can be exhausting, as we all know. Can you think of an example, Adele, where maybe that with a typical diagnosis where we see maybe carer fatigue can be
Absolutely. Yeah, there's so many diagnoses where quite significant intensive care support is required in a non-cancer setting, motor neuron disease, absolutely, where patients become quite debilitated over a period of time. Some times the deterioration is more rapid than others. And there's so many aspects of care for this particular patient group, to not just to support to support these patients physically, which comes at not just a physical burden for the carers, an emotional burden, a psychological burden. And it's, as you said, Sarah, that 24/7 care it's difficult even from a palliative care unit perspective, where we have shifts of staff to be able to provide that care. And I often think about how challenging that would be for one person or even a handful
of people to achieve. So that patient group is particularly notable for me.
Anyway, of support, absolutely. And I think it's quite commendable and honourable that family members are doing this 24/7 for our loved ones at home. So thank you, Adele. Adele, there's lots of misconceptions and myths about palliative care, we say. We do like to say it's a myth magnet, which it is. People think some really weird and wonderful things about what we do. So do you think there's any misconceptions, any myths that people listening or families listening may have that might stop them from reaching out to us, do you think? Can you think of a couple?
Unfortunately, there are myths, and there can be stigma and fear attached to the P word. And when palliative care is first introduced, what people may hear is that there is nothing more that can be done, that I've no more options, that death is imminent, that my doctors have given up on me, and that you can't have palliative care and other medical treatments. There's also a fear or a misconception that palliative care hastens death. And this couldn't be further from the truth. A lot of the time we're looking after patients who are continuing to receive cancer treatments and life-sustaining, life-prolonging measures. And the support that palliative care provides often helps a patient to maintain function and to maximise quality of life so that these treatments can continue and can continue with more quality of life, and it makes the treatments easier. So the way this happens is by collaborating and communicating with other medical specialties, and this is something we do every day. Just to demonstrate this or to illustrate this, I remember a conversation with a wife of a patient we were caring for in our palliative care unit, who said that they were really reluctant to have palliative care involved because of the fear that they would no longer have contact with their treating team, and that the treatment
Options would be limited. Despite this, they had the courage to have palliative care involved. And this meant that for 2 years, this couple were supported in the ways that they needed to continue treatment. And what this lady actually said, live their best lives.
Wow.
Yeah.
I love that.
Yeah. And just to add further, it was listening to this podcast that helped this couple understand that the time was right to come to the palliative care out.
Wow, that's it.
That friend of life can land.
That is incredible, Adele.
That was a really special story, I felt.
Yeah, and that means a lot to us that people are actually listening to this and understanding what we do. Thank you.
Absolutely. Well, so I thought it was a wonderful conversation, really, to illustrate how palliative care works.
Yeah.
Perhaps another common misconception or the stigma attached to palliative care is around the use of morphine or other medications that we use. Particularly morphine and opioids. It's worry about addiction. It's worry about dependence. Sometimes the fear or the understanding that not using morphine means final days of life. So, of what we do know in palliative care, that morphine and opioids are really well understood medications that are effective and useful in palliative care diagnoses. And that's been used for a very long time and used in the right way for the right purpose are very safe.
You said, I think it can put people off for a long time. And then when they come to us, it's like living your best life because we try and support you with all of that. I think there's some really key points there, which means that people often think that we're the last option, and we're not the last option. We give you more options, or we like to hope so. And I think that's a really important point when we're talking about medications. That can often be a really big, scary part of what people fear is around morphine. And morphine's got this terrible reputation for absolutely no reason, because it is a medication that we're only going to use if somebody has pain or breathlessness, and that there's people walking around at the local shopping centre every day that are having these medications. And so, but it's that fear, and we can talk to you about these fears, which I think is a really good point for us to make today. Thank you both. I think to summarise the key things, what are some of the key points that we really want our listeners to take away from today? Adele.
Thanks, Sarah. So I've got some buzzwords. Collaboration with patients, other treating teams, families, friends, loved ones and caregivers, conversation and communication, complementary to other care, and that care is customised. I think it's important to say that palliative care doesn't hasten death or speed up the dying process, and there are medical studies to prove this. And finally, we can't always cure, but we can always care.
Yeah, that's quite special, joyful. I like that. Ali, any last thoughts to summarise from you?
Well, in keeping with what Adele just shared, I feel like more often than not, there's an enormous sense of relief that comes from families arriving to palliative care, where they can sometimes what seems quite complex can actually be quite simply managed, in a simple way. It's what we do, and so. Yeah, it's really nice to be able to help and support and smooth the way for these families and their loved ones.
Thank you, Ali. I think it's very special, and that's why we love what we do and why we do it every day. Thank you both so much for coming and for all of these fabulous insights. We obviously want people to understand that we are there for everybody. We're there for the patient, but we're there for the person, we're there for the families, whatever that might look like. And I hope that we've addressed some of those topics today for everybody listening. If anybody's got any questions, we do have the Palliative Care Consumer Line. If you're in WA, it is a great resource to call up and ask some questions about anything that you might wonder about today that you've heard here. This episode 2 forms a part of a series on palliative care, so look out for the next episode if you enjoyed this one, which we hope you did. And thank you, Ali, and thank you, Adele, for coming. You've both been fabulous, of course. And thank you, everybody, for listening.
Thank you,
so
Sarah.
much.